This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Thank you for joining us today for our HealthyU webinar series, Get to Know Your Gut, sponsored by New York Cancer and Blood Specialists. Please enter any questions you may have using the question and answer feature at the bottom of your screen. We'll answer as many as we can with the time allotted towards the end of the presentation. I'd like to introduce to you to today's presenters, Dr. Ramona Rajapaksa and Dr. David Schwartzberg. Dr. Rajapaksa obtained her medical degree from the Royal College of Surgeons in Ireland and is a Fellow of the Royal College of Physicians in England and a Fellow of the American College of Gastroenterology in the United States. Prior to joining Mather Gastroenterology, she was at Stony Brook University School of Medicine, where she was on faculty in the Division of Gastroenterology for 20 years. At Stony Brook, she was the director of the Inflammatory Bowel Disease Center. She partnered with the Crohn's and Colitis Foundation to educate the community and fundraise for research. In addition, she is active in the National Public Policy Council of the American College of Gastroenterology. She's board certified in gastroenterology and has a special interest in inflammatory bowel disease and women's health issues, in addition to general gastroenterology and colon cancer screenings. Dr. David Schwartzberg has just returned back to Long Island to open his colon and rectal surgery practice in Port Jefferson, New York at Mather Hospital. During his residency, he completed research in colorectal oncology at Memorial Sloan Kettering Cancer Center and was the recipient of the Dr. Murray Brennan Resident Scholarship. He graduated from NYU's General Surgery Residency and then completed a fellowship in colon and rectal surgery at the Cleveland Clinic in Ohio. He subsequently received additional training in complex inflammatory bowel disease and was on faculty at NYU Langone in the Inflammatory Bowel Disease Center. He's proud to be back on Long Island to provide complex and compassionate treatment all on Long Island. He's interested in treating colorectal cancer, inflammatory bowel disease, diverticulitis, hemorrhoids, anorectal abscesses, and anal fissures. He's available for same-day appointments, virtual visits, and takes all insurances. Dr. Rajapaksa, go right ahead.
Hello and good afternoon. Thank you very much for inviting me to give this talk. I have no disclosures. So I am currently part of Mather Gastroenterology, which is located opposite Mather Hospital, as you can see from that map. So before I start, I sort of wanted to let you know what gastroenterology is all about and what a gastroenterologist does. So gastroenterology is a branch of internal medicine that focuses on the diagnosis and treatment of digestive diseases. So we see patients who have abdominal pain, change in bowel habit, rectal bleeding, heartburn, regurgitation, nausea and vomiting, weight loss, difficulty swallowing, and gallstones. And some of the diseases that we treat are GERD, irritable bowel syndrome or IBS, IBD, diverticulitis, cancer, ulcers, pancreatitis, and hepatitis. Now we can actually visualize the entire gastrointestinal tract through endoscopies, different types of endoscopies. So we can see anything from the mouth all the way down to the anus. And we can do this with upper endoscopy, where we put a tube down into the stomach, with a pill cam, which is basically a camera in the form of a pill that one can swallow, and it tumbles through the small intestine, allowing us to visualize the small intestine. It's actually quite small. It's about 1 centimeter by 2 centimeters across. And then we can visualize the colon as well. So we can actually visualize the entire GI tract in order to be able to make diagnoses. So I wanted to start with basically, what you should do if you have no symptoms. So when you think about your gut, if you have no symptoms at all, and if you're age 50, or if you're African American and age 45, the best thing you can do for your colon is to get screened for colon cancer. Now, if you do have a family history of colon cancer or polyps, or if you have a personal history of Crohn's disease or ulcerative colitis, then you should get screened for colon cancer at an earlier age, and it's something that you should discuss with your doctor. Now, colon cancer can occur anywhere in the colon. I have a diagram up which shows you different parts of the colon. There's the right side, which is the ascending colon and cecum, the middle, which is the transverse, and the left, which is the descending and sigmoid. And then there are rectal cancers, which are slightly different to regular colon cancer. So I wanted to give you some statistics, which are really, quite interesting and important to understand. Colon cancer is the second killer among cancers in the United States. So that is big. There's a 1 in 20 likelihood of developing colon cancer during your lifetime. And there are about 148,000 new cases of colon cancer each year in the United States. But in spite of that, and in spite of the fact that we have screening and really efficient screening methods for colon cancer, 1 in 3 American adults who aren't screened for colon cancer are not screened for colon cancer as recommended. So that amounts to about 23 million people in total. And with colon cancer screening, there's a 90% reduction in cancer risk following colonoscopy and polypectomy. So when you think about that, that's quite startling. So this year, more than 53,000 people are expected to die of colon cancer. And screening can save more than half of those lives. That's a lot of lives. The problem with colon cancer is that it's often silent, and it's silent until late. So usually patients don't have any symptoms. But if you do have symptoms, one might have abdominal pain, change in bowel habit with diarrhea or constipation, rectal bleeding, loss of appetite, unintentional weight loss, or anemia. So which screening test is most effective? Well, there are actually 3 tiers of screening tests that are available. And the U.S. Multi-Society Task Force on Colorectal Cancer recommends that physicians offer colonoscopy first. And the reason is because it's not just a cancer detection test, but it actually prevents colon cancer. And I'll keep repeating this over and over again because it's important really to understand. If patients decline a colonoscopy, then you can do an annual fecal test, and then you can go on to the 2nd tier or 3rd tier tests, which are also recommended but not as good as colonoscopy. And the reason for that is because colonoscopy detects polyps. So this is a schematic representation of how a cancer develops. So it starts off, you have normal epithelium, and then you develop small adenomas, which can then become a large adenoma, which can then become colon cancer. Now, a colonoscopy will detect anything up to colon cancer, and removal of a small adenoma, for example, or a large adenoma, essentially prevents it from becoming cancer. Now, all the stool tests, the FIT tests, Cologuard, and so on, they only detect colon cancer once it is a cancer already. They are not very effective at diagnosing polyps. So it's important to remember that colon cancer is preventable. Like I said, you have a 1 in 20 chance of developing colon cancer in your lifetime. This year, it's expected that colon cancer will cause 50,000 deaths, and colon cancer can reduce that, colonoscopy can reduce that risk by about 90%. So as I mentioned, small growths in the colon are called polyps, and removal of those polyps is how we prevent colon cancer during colonoscopy. So these are some pictures of polyps detected during colonoscopy. They're all of different sizes and shapes. On the top left, you see quite a large one. On the top right, you see one with a stalk. On the bottom right, you see a flat polyp, which are sometimes kind of difficult to see on colonoscopy. And this is how we remove them. We do a colonoscopy, we find a polyp, we remove it, we fulgurate the base, and it's gone. So essentially, we have prevented colon cancer. And it's very interesting when you think about it that there aren't many cancers that we can actually prevent. But colon cancer is one of them. We do not prevent breast cancer. We do not prevent prostate cancer. We detect them, but we don't prevent them. But colon cancer can be prevented. It affects both men and women. It's most common after age 50, but it can occur in younger patients as well. And really everyone is at risk if they live long enough, because the most important risk factor is age. So when you consider the risk factors for colon cancer, there are those that are changeable and those that are not changeable. So for example, the unchangeable ones are a family history of colon cancer, family history of polyps, and a personal history of ulcerative colitis and Crohn's. So if you have any one of these, then you should really just start screening early. How early, you might ask? Well, you have to discuss that with your doctor. It depends on the family history. Now, what about the changeable ones? What can you do to lower your risk of colon cancer? Well, having a healthy lifestyle is important. If you're obese, try and lose weight. Eating lots of fruits and vegetables, avoiding processed foods, avoiding red meat, and exercise are all important in helping to reduce colon cancer. And again, I can't emphasize this more, that you really cannot wait until you get symptoms to get checked out, because half of those who are diagnosed after symptoms develop will die from cancer. So screening is important. So the preferred colon cancer prevention test is colonoscopy. In the absence of polyps, colonoscopy is recommended every 10 years. For normal risk individuals, you should start at age 50, and if you're African American, then you begin screening at age 45. Okay, so now we talked about patients who don't have any GI symptoms at all. Now, what about if you have abdominal pain, diarrhea, constipation, bloating, any combination of these symptoms? And if they're persistent, not a once-off, but symptoms that come and go every couple of weeks, every couple of months, well then, you know, there are many different causes of these symptoms. It could be dietary, something such as gluten intolerance, lactose intolerance. It could be cancer, inflammatory bowel disease, irritable bowel syndrome, or infections. So this is where you need to see your doctor and consult a gastroenterologist to define this further. Now, in the next few minutes, I'm going to talk to you a little bit about irritable bowel syndrome and inflammatory bowel disease. Irritable bowel syndrome is an intestinal disorder causing abdominal pain, bloating, gas, diarrhea, with or without constipation. The cause of irritable bowel is unknown, but it's very common and it impacts more than 35 million Americans. It does not cause lasting harm to the bowels. It does not lead to cancer, but it can impact you physically, emotionally, and socially. So it does have consequences, although it doesn't have long-lasting consequences on the bowels themselves. So what causes irritable bowel? Well, there are many theories. We believe that it's due to dysmotility, i.e. poor regulation of the muscle contractions of the gut. There's a certain amount of visceral hypersensitivity so that the gut is more sensitive than usual. And there is also an element of brain-gut dysfunction, which can lead to increased symptoms during periods of stress. But again, I want to stress that IBS does not cause lasting harm to the bowels and doesn't lead to intestinal bleeding. So what are the types of irritable bowel or IBS? There is IBS-D, which means that it's diarrhea predominant. There's IBS-C, which is constipation predominant. And there's IBS mixed type, where you can have symptoms of diarrhea sometimes and symptoms of constipation sometimes. And it's important to remember that patients don't always have to have only one type. So for example, when you're young, you could have IBS-D, and then this could move on to IBS-C when you're older. So it does vary. So in IBS-C, or constipation predominant IBS, food moves too slowly through the bowel, and that causes stool that's hard to pass. Whereas in IBS-D, for example, the intestines are irritable and food passes quickly through the bowel, and this causes a watery stool, which is often, again, accompanied by abdominal cramps and bloating, which are important features of IBS. So how do you make a diagnosis? Well, the most important thing is a complete history and physical, which will be done by your doctor, by your gastroenterologist. Now, we might do some other tests in order to rule out other causes, such as gluten sensitivity, such as inflammatory bowel disease, and so on. So there are lab tests that we might do. We might do a colonoscopy, a pill chem examination of the small bowel, and sometimes imaging such as CAT scans and MRIs in order to make the diagnosis. But it's essentially a clinical diagnosis. And what are the treatments? Well, there are varied treatments. The most important one is self-care, meaning a high fiber diet, exercise, stress management and relaxation. But other therapies that we use are medications depending on what is the predominant symptom. So for example, if diarrhea is the predominant symptom, we use antidiarrheals, we can use antispasmodics, laxatives, and we also have these neural or nerve pain modulators, especially to help with the abdominal cramping. There are behavioral and biofeedback mechanisms as well. We use probiotics, you might have heard of. Probiotics are good bacteria, which you can sort of supplement into your intestines. And then we have different types of diet that can help with gas and bloating, such as low FODMAP diets. Now I want to change gears a little bit here. And remember at the beginning I said if you have abdominal pain, diarrhea, one of the differentials is irritable bowel syndrome. Well, the other one is inflammatory bowel disease, IBD. So I wanted to be very clear that IBS and IBD are two very different diseases. Irritable bowel syndrome is more of a functional problem with the gut, and inflammatory bowel disease is an inflammation of the gut. So it's basically inflammation or swelling in the GI tract and a lifelong immune response. Symptoms can differ from person to person depending on the type of inflammation. There are two main types, ulcerative colitis and Crohn's disease. It affects men and women equally and often young patients, but it can occur at any time during life. And essentially what happens is that the body and immune system think that bacteria and other needed things in the intestine are not supposed to be there. And it sort of starts to attack the cells of the bowel, causing inflammation, which doesn't go away on its own. So when you think about ulcerative colitis, it affects only the colon. It can affect the rectum alone, the left side of the colon, called the left-sided colitis or pancolitis. Presents with clinical features such as abdominal pain, diarrhea, weight loss. Bleeding is quite prominent, and you can have extraintestinal manifestations outside the GI tract as well. Crohn's disease differs from ulcerative colitis in that it can affect any part of the intestinal tract, from the mouth right down to the rectum. And again, it can present with abdominal pain, diarrhea, fevers, weight loss, and extraintestinal manifestations. So how does one make a diagnosis? Again, a very complete history and physical is important. But I want to point out that there isn't a single diagnostic test for inflammatory bowel disease. So there isn't a lab test that we can order or a specific pathology that tells us this is absolutely inflammatory bowel disease and nothing else. So we use a combination of history and physical, lab tests, scoping, and imaging in order to make the diagnosis. On the top right-hand corner, you'll see an image of a normal small intestine using the pill cam. And in the bottom right-hand corner, you see somebody with Crohn's disease with ulcerations. All the white stuff is the ulceration. And what about treatment? Well, the most important therapy for inflammatory bowel disease is actually medication. It is very important that patients see an IBD specialist, and we have this concept of the IBD team and personalized care. So what do I mean by personalized care? It means that the treatment has to be tailored to the patient, because no two IBD patients are the same. And we can do this with lab testing, with the demographics, depends on the patient's age, sex, their lifestyle, other medical conditions, and so on and so forth. So this concept of personalized care is very, very important. The other important concept is that of an IBD team. The main players in the IBD team are actually the IBD specialist, who's a gastroenterologist like myself, and the IBD surgeon. And those are the two main players, and then we have lots of other people around who are also important in the IBD team. So as I was pointing out, medication is the mainstay of therapy, and whether we use a step-up approach or a top-down approach really depends on the degree of inflammation and various other factors to do with the specific patient. And that's why we say that it's personalized care. And when medication fails or is unsuccessful, or when there's a complication, then patients require surgery. There are some endoscopic treatments we can do for inflammatory bowel disease. For example, if there's stricture and narrowing, we can use balloon dilation, which is what you can see on this image. On the far left is a stricture, then you have the balloon dilation, and the stricture opened up in the bottom right. I'm sorry, I lost you for a second there. We also are involved in research, very much so, with the Crohn's and Colitis Foundation. And this is a picture from a couple of years ago. So I wanted to change gears very briefly and talk about gastroesophageal reflux disease. So if you have symptoms of a sore throat, heartburn, difficulty swallowing, you might have what we call GERD. Gastroesophageal reflux disease. So what is this? It's essentially when acid moves from the stomach up into the esophagus. So normally the stomach is very resistant to acid, and there's a thick layer of muscle at the lower end of the esophagus, which prevents acid from moving up into the esophagus. But in gastroesophageal reflux disease, this thick layer of muscle is loose, and it allows acid to go up into the esophagus, causing heartburn. Now, it's important to understand that the majority of patients with heartburn don't actually see medical care, and we call this the GERD iceberg. We only see the tip of the iceberg as gastroenterologists. So why do we pay attention to GERD? Well, aside from the nuisance value and the pain, it can cause complications. And the most serious and severe complications are Barrett's esophagus, which is precancerous, and esophageal cancer. But you can also get esophageal ulcers, pulmonary complications such as cough and recurrent pneumonia, and so on. How do we make a diagnosis? Again, complete history and physical is important. We also do endoscopic evaluation, and we can also do esophageal pH monitoring and measure pressures in the esophagus. How do we treat it? Well, number one is lifestyle. It's important to avoid heartburn triggers such as caffeine, carbonated beverages, It's important to avoid lying down for 3 to 4 hours after a meal, to quit smoking, to avoid alcohol, and so on and so forth. And these lifestyle measures are available freely online. If lifestyle measures fail, then we go on to medications such as antacids, H2 blockers, PPIs. Some of these medications are available over the counter, and some of them are prescribed. We also use neuromodulators in order to help desensitize the esophagus in certain cases. Now, if medication fails, then we go on to endoscopic procedures and surgery. So I wanted to leave you with this. You know, when you think about your gut, the most important thing is to try and prevent disease. And how do you do that? Well, remember to get screened for colon cancer. If you're age 50, or if you're African American, then at age 45, or if you have a family history of colon cancer, colon polyps, please get screened for colon cancer. Colonoscopy prevents colon cancer, and it's important that you talk to your doctor. Now, at Mather Gastroenterology, we have set up a direct access colonoscopy program to try and make it easy for healthy patients to schedule a colonoscopy without an office visit. So the number is on your screen, 631-975-COLO. You can give us a call and we'll walk you through it. I also wanted to point out how important it is to have a healthy lifestyle. Now, what about if you have persistent symptoms? Well, then you need to talk to your gastroenterologist. Thank you. Thank you.
Thank you so much, Dr. Rajapaksa. We appreciate you taking time out of your day to join us. She's going to be logging off now, and we're going to introduce Dr. Schwartzberg. Give us one moment. Dr. Schwartzberg must have stepped away from his desk. Hang on with us for 1 second. And Dr. Schwartzberg, you're all set?
Yeah, I think so.
Great.
Sorry, keeping things safe here in the office. Sorry, everyone. I just had a patient who needed to be seen real quick. But I'm here. My hair is sticking up as usual, so good. Everything's perfect. No, I'm on the side. Hi. Good morning. Sorry for being a little late. I'm just taking care of a patient in the office, but I wanted to kind of be the complement, which in many ways I am, to Dr. Rajapaksa, who just finished, looking at, you know, the gastroenterologist and the colorectal surgeon are essentially, you know, hand in hand with diagnosing and treating a lot of these conditions. And I think we both have the mindset that we would like to minimize any operation if we could, but sometimes the safest and the quickest way to feel better is to actually undergo an operation. And some of these things are very small operations. Some of these are very big operations, but in many ways, if it's dealing with cancer and things like that, it's an opportunity to cure the cancer. And that's why we work so well together and so closely with our gastroenterologists, and why I think it's so important to be in a healthcare system, or, you know, have doctors who do communicate on a daily basis, because a lot of these decisions are not so black and white, and a lot of them require a lot of dialogue between the physicians to really offer the best care we can for the patients. I have no disclosures. I live by this saying, as we all do in the office, that the best interest of the patient is the only interest to be considered. It's not about money for us. It's not about time. Whatever we can do to help the patient is what we do in this office. I have a mug that says that. So I am from Setauket. There's a nice picture right on 25A. So I'm from here, right in Long Island. Finished my residency at NYU in the city, and then went to Cleveland Clinic for colorectal fellowship. And then I came back to join the Inflammatory Bowel Disease Center at NYU, bring with me, a lot of experience. I did my research at Sloan Kettering, so there's a lot of cancer background that I have for colorectal cancer. And then going to Cleveland Clinic and then working at the Inflammatory Bowel Disease Center, I have a lot of experience with Crohn's disease and ulcerative colitis as well. You can hit the 2 buttons. So the thing is, we had, both is fine. We had 3 children, and we realized that the city was a little impossible to live with 3 kids. So that's why we came back to Long Island, and we now started this practice between gastroenterology and surgery, where, your next slide, that we now have these people starting with us. The idea was to come out here and bring, on that top left picture, that was when I gave grand rounds at Peconic Bay. I think a lot of our background is in academics, and we like not only taking care of patients, but educating the public and educating residents and fellows on how to do things, we think, the appropriate way. So one of the things was come out here and educate people, educate residents, give grand rounds, host things like this with HealthyU, accept all insurances, which is a big deal out here. There's a lot of physicians who don't take insurance, and a lot of times the patients aren't even aware that they don't take insurance until they get a bill. And coming from these academic centers where money was never a concern, it was always what to do to best care for the patient was our only prerogative. And when I say we, I see on the screen right, the Mather surgeons now. When I first came out here, we now have Dr. Abuzed, who is a general surgeon, and Dr. Defnit, who just started. And both of them trained at NYU with me and are excellent surgeons. And now we have the colorectal and the general surgery. And in addition, Dr. Defnit is an upper GI surgeon and does a lot of advanced, minimally invasive techniques. So now we have these people who all trained in a similar fashion, who all take insurance and who all work with each other to really take care of any surgical problem anyone should ever have, to be honest. And the idea, the next slide, the idea was to build a team. And this is just, that was a picture of building a team at Mather. And we have our care coordinators and our nurses and our respiratory therapists and our physical therapists. And so if someone has an operation at Mather, they're cared for by an entire team of people who now are used to seeing surgical patients, and they care for them in the way that we're accustomed to. Point of what I was saying before, there's diagnosis and there's treatments, but the truth is it's not very easy sometimes to have a diagnosis. And sometimes not just seeing one person is how you're going to get a diagnosis, but seeing gastroenterology, who refers you to surgery, and surgery evaluates, and we send for a test, and we send back to gastroenterology. And that's really the only way to truly figure out what's best for a patient. And a lot of it is a lot of trust. So we like to establish trust with our patients early on, because a lot of these things take some time. Everyone wants a quick fix. Sometimes slow and steady wins the race, and working things up appropriately and slowly is actually the best way not to rush into a medication or to rush into surgery. We like to kind of do things together with the patient. And that's why I have those, the hand in hand is really working with the patient to best care for them. So looking at something that's pretty common, and I think Ramona touched upon, it's diverticulosis, which everyone has. And if you have ever seen your colonoscopy report, if you've had a colonoscopy, it always mentions diverticulosis. Those are just little sacs. They're around the colon. Some people think they're, in the Western world, it's very common. It's because there's maybe a low fiber diet. A lot of times they're asymptomatic. Diverticulitis is when one of these little sacs gets inflamed. Now, there can be very straightforward diverticulitis, which maybe requires some, rest of the bowel, have some liquids for a day or two, and maybe take some antibiotics. And then there's diverticulitis that causes people to become very sick, septic even, and sometimes they have to undergo emergency surgery. The idea is to, even if someone needs surgery, to hopefully avoid emergency surgery. If you see on the bottom, the colon resection involves taking out the area that has the majority of the diverticuli. Those diverticuli can become diverticulitis. And you take out the majority of those. by removing the sigmoid colon, and then you connect the two ends. And usually the patient has that done in the hospital, and then goes home in 2 to 3 days. So that's always an option, that when people are having these attacks over and over and over again, or they're having symptoms even after the attack is over, such as pain, or maybe it's hard to move their bowels now because things got narrowed. That's a lot of times when you see a gastroenterologist have a colonoscopy and a colorectal surgeon to take out that segment possibly. So this slide is not necessarily for everyone to read per se, but just to realize that there's a lot going on talking about diverticulitis, and it's best, and I have some slides on this, it's best to be treated by someone who's had experience not only with performing this operation routinely, but also has had advanced training, because there's a lot of kind of tricks that can change an emergency surgery to an elective surgery, or can change a big incision on someone's belly. It's just tiny incisions with what's called laparoscopic or minimally invasive surgery. And there are also, every time we're talking about diverticulitis, there's a chance of having a temporary colostomy bag. Now, some things we can do in the operating room can change that percentage of having a colostomy bag to maybe just single-digit percentages, or the time when they have it. Maybe they don't need it for 6 months, maybe just 2 to 3 months. So all these things are relevant, and these things are really only possible if that, sometimes things happen a little too quick. Patients go to the hospital and they get seen by a surgeon, they're in the operating room, and maybe that surgeon doesn't have a lot of experience with diverticulitis. You're always going to wonder, well, if I had seen a colorectal surgeon initially, would I be in a different situation right now? Maybe not having a temporary colostomy bag. Maybe I wouldn't need a big incision. I just had a small incision, which is why we like to really talk to patients about diverticulitis and their treatment, even if they haven't had a major attack, maybe just 1 or 2 small minor attacks, because at least we can establish a relationship where if they should happen to have an attack that required an emergency surgery, we already kind of have a game plan. Again, talking about subspecialization, not just general surgery, but then being subspecialized in colorectal surgery at Cleveland Clinic, and then again, specializing again, doing complex surgery back at NYU, that the complex cases, at least in our practice here, are pretty common. And that's kind of what we specialize in, is doing cases that a lot of people would typically send to the city. The idea with me and my 2 co-surgeons coming out to Long Island, we were in the city and we were seeing a lot of patients that were schlepping to the city from even more out east than here, from Wading River, from Ridge, from the Hamptons into the city, because they thought the only way they could get expert city level care is in the city itself, and kind of our passion was to bring that city level expertise to Long Island. And so looking at subspecialization, I just showed some of the things, some of the training I had. This is an example from a very recent study just a few months ago. The study's BC, before COVID. And subspecialization, better outcomes. So they looked at all these operations that were done, and looking at the colorectal surgeon, which is the column in the middle, versus just an acute care surgeon, which is the column on the right, the mortality, which unfortunately is death, way decreased with the colorectal surgeon. The morbidity, which is complications that happen, wound infections, maybe someone throws up, things like that, a urinary tract infection, way down with the colorectal surgeon. The need to unfortunately have to go back to the operating room, way down with the colorectal surgeon. The length of stay in the emergency cases, also way down with the colorectal surgeon. So this is, a clear indication by looking at a total of about 1,000 patients almost, looking at, patients who are operated on by general surgery versus colorectal. And the truth is, every outcome you can imagine is better with the colorectal surgeon. I have nothing against general surgeons, but this is what the data supports. Same thing, looking at diverticulitis specifically. Less stomas, meaning temporary bags. Lower mortality, meaning death. These are serious cases with the colorectal surgeon. So yes, do I feel very passionate that patients who are being operated on by a colorectal surgeon doing colorectal surgery do better than a patient being operated on by a general surgeon doing colorectal surgery? Yes, I do. And if it was my family member, I would want them to be in the hands of a colorectal surgeon. Because this, again, this is the operative side of diverticulitis. You can have diverticulosis, and the majority of people who have diverticulosis never develop a problem. But if the patients do, I want them to be in the right hands. It doesn't have to be me, but I would just implore them to go to a colorectal surgeon to take care of colorectal problems. I do a lot of inflammatory bowel disease. So does Ramona Rajapaksa. She's one of the best, IBD gastroenterologists there is. I'm her yin and yang, her counterpart on the colorectal side. I would say that her and I work so closely together because a lot of our patients see both of us, because really appropriate IBD care requires subspecialization, and it requires a lot of dialogue between the patient, the colorectal surgeon, and the gastroenterologist. The next slide is really going to show really what it takes to appropriately treat patients with inflammatory bowel disease, with Crohn's disease, and with ulcerative colitis. And this is how it's done at NYU, this is how it's done at Cleveland Clinic, and this is now how it's done at Mather because of us coming here. There's a lot that goes into treating a patient appropriately, and we really feel we're starting to work within the system here to see inflammatory bowel disease patients who otherwise would have to go to Manhattan. And it's not easy to schlep into Manhattan. It's not easy if you have surgery for your family members to come visit you. What if this is a complication? What if you have to stay there for a few weeks? Sometimes, you have to stay in a hotel that's not costing money, or no one can visit you and you're in the hospital alone. There's a lot of reasons to see if your IBD care can be managed here on Long Island. And it has to do with not only, it's mental reasons more than anything. The anxiety of being stuck in a hospital and not having your family members come visit you. I've seen it myself. It is difficult. It's really difficult. Next slide. And then we were just looking at, what is inflammatory bowel disease? Some people have patients, family members who maybe have one or the other, Crohn's disease, ulcerative colitis, and then indeterminate colitis happens to be one of the other two, whether it's Crohn's disease or ulcerative colitis. We don't know which it is yet. This is what I mean, that a lot of these diagnoses take a lot of time to figure out, and it should be done, the appropriate way. The incidence is rising. We don't exactly know if it's environmental factors, we know it's related to some genetics. So it's very common in family members, but we don't really know if it's the immune system imbalance, disturbance. I happen to think the rate of IBD is going up so quickly that it probably is what they put in the food, to be completely honest with you. And I think there's a lot that has to do with dietary changes, and we have a dietitian that works with us. Some dietary changes sometimes can actually improve someone's inflammatory bowel disease. Next slide. So again, the incidence is going up. It is very common. A lot of patients, even with medical treatment for, let's say, Crohn's disease, will still need surgery. 30% of patients with ulcerative colitis will still need surgery. So it's nice to be in a healthcare system where the gastroenterologist and the colorectal surgeon, work together. Next slide, thank you. These are some of the kind of surgical techniques, and the idea is not to look at any one particular picture, but the point is these techniques, which in my opinion are standard of care for patients with inflammatory bowel disease, are not techniques that a lot of general surgeons know. And this is why when it comes especially to inflammatory bowel disease, there are things that should only be treated by specialists, not even people who sometimes went to do colorectal fellowship, additional fellowships, additional subspecialization, because the difference in kind of what some of these pictures are is life and death to some patients, and suffering versus going back to their life for other patients. So you have to go into these operations knowing basically every trick in the book, because one of these little tricks, not really tricks, but little bits of knowledge that can really help a patient. And this is why I think IBD care needs to be subspecialized. Next slide. The idea, my mentor used to say, Feza Remzi was at NYU. The idea and the art of colorectal surgery is thinking 2 and 3 steps ahead. And that is how you take care of patients. That is how you get out of trouble. That is how you keep them out of trouble. That is how you get them back to their lives. It's by thinking 2 and 3 steps ahead. So as a patient, you're going to see a surgeon. What are you allowed to ask? Well, look at the skill set of the surgeon. Look at the people they're surrounded with. Ask about the team. Ask about the approaches. Ask about alternatives to surgery. These are things that as a patient you should be fully ready to say and ask to the surgeon. You don't have to feel shy about these things. They should have the answers to these. You can ask, what's your experience? Where did you learn these skills? You know, are they available? Are you going to be able to reach them? Are they going to round on you? Are you able to communicate with them? You shouldn't be afraid of your surgeon. Are they able to do these things? And are they accountable? They're going to come in on the weekends. They're going to come in at midnight. They're going to come see you. A lot of the surgeons can fill 3 out of 4 or 2 out of 4. The idea is to find a surgeon who has the 4 A's: available, affable, able, and accountable. You can ask, is it going to be minimally invasive? Little incision, big incision? You know, what kind of operation do you think is right for me? Will I need an ileostomy or a colostomy bag? If it's for cancer, do I need lymph nodes removed? How long will the surgery take? What is the recovery like? What's it like to recover at home? All these things are very relevant questions. You're allowed to ask these things to the surgeon if you happen to need one. Now something a little, maybe not as severe as inflammatory bowel disease or colon cancer, but looking at things what most people refer to as hemorrhoids. It's amazing how many people come in and, they're sure it's hemorrhoids. They spoke to their friend. They spoke to even their primary care. They definitely have hemorrhoids, but it turns out not a lot of things, are hemorrhoids. There's a lot of things that are related that can cause bleeding, that can cause itching, that can be a lump. They can even have some tissue they feel when they come to the bathroom, and they can have pain. Not all these things are hemorrhoids. Some of them are. Some of them things are not severe, but they should be addressed. And certainly in our office, there's no one is shy about anything. We simply want to help as many people as possible. We don't want people to come to the office. We don't want things to get worse before they can get better. So some people have a fissure. Some people have terrible, terrible pain. Sometimes there's blood. Sometimes there's very simple treatments, such as taking warm baths a few times a day. Sometimes warm baths 3 times a day can actually relax that muscle to a point where the fissure heals on its own. Sometimes we have to add some topical medications to help relax that muscle so it can heal on its own. Sometimes that doesn't work, and then surgically we can inject something like Botox, which helps relax that muscle. Lastly, we can cut a piece of the muscle to relax it. The whole idea is just to relax the muscle so that muscle can heal. Relax the muscle, heal the fissure. Blood, pain, come to the office. We'll take a look. We'll see what we can do. I might just be starting you on some Tylenol, some fiber, and some warm baths. Sometimes this is just a little cartoon of the fissures injecting Botox. There's no cutting. All we do is take a tiny needle when you're asleep and inject the muscle with some Botox to help relax that muscle. On the right, you can see sometimes you do have to cut the muscle. Again, these are things that only take about 15 to 20 minutes in the operating room and make the world of difference for a patient who's been suffering with severe pain. A lot of times the pain is terrible after a bowel. We can also look at hemorrhoids. A lot of hemorrhoids are able to be dealt with by simply changing someone's diet, giving them more fiber, having them take baths after each bowel movement. And then sometimes we can do what seems scary, but it's actually completely painless, is a rubber band ligation for internal hemorrhoids right in the office. We put a little suction device on the hemorrhoid, and we deploy the rubber band. And in about a week or so, the hemorrhoid falls off and there's no more bleeding and there's no more irritation. Again, looks a little crazy. It looks like it's something that would hurt, but it truly is completely painless. There's just no nerve endings. It's like getting a haircut. There's no nerve endings and it doesn't hurt. Now there is, on the lower picture, is an example of actually doing a hemorrhoidectomy. And sometimes that is needed. There's, I think the gold standard of a hemorrhoid surgery is in fact a hemorrhoidectomy, meaning remove it. The problem is, it's, although very successful, it's extremely, extremely painful. So I try to do everything I can to avoid ever having to perform a hemorrhoidectomy, if at all possible. It has its time and its place, and it does get rid of internal and external hemorrhoid disease. But again, I would rather do a few rubber band ligations in the office where someone has no pain than to do even one hemorrhoidectomy in the operating room. Next slide. So what I try to do is something called a THD. It stands for transanal hemorrhoid dearterialization. But what it does is use some sutures to help shrink the hemorrhoid. And even more than that, it helps bring the hemorrhoid back up. So people are feeling the hemorrhoid come down, it keeps where it is. Now, it's not exactly painless, but it's certainly not anywhere close to an actual hemorrhoidectomy. This is something that I'm doing more and more lately because I think the patients are benefiting from it and they're not really in postoperative pain. And that's a big deal. So this is something that gets rid of the bleeding and gets rid of the prolapse coming out of the anus with the bowel movement. And it takes about a half hour in the operating room, but postoperatively, maybe just some Tylenol. Big difference between the severe pain of a hemorrhoidectomy. So this is something we're trying to do to benefit our patients as well. Lastly, looking at colon cancer, I know it's a hot topic right now because the actor had passed away, and combine that with COVID, where people were not really able to get screening colonoscopies. I think a lot of people are getting screened, and good. You know, we have to screen these things. The idea is that a gastroenterologist removes these polyps before they ever turn into colon cancer. That is the ultimate goal. And that's why we have these screening guidelines, to remove the polyp before it turns into a cancer. Colon cancer is the fourth most common cancer in the US, but the second most common leading cause of death, unfortunately. There's a lot of things we can do that are new for colon cancer. So on the top, there's something called a TAMIS procedure. So even if there's a very big colon that, a very big polyp in the colon or the rectum that historically needed to be treated with surgery through the abdomen, sometimes we can actually go through the anus and remove these polyps, and the patient goes home the same day, and literally there's no pain. So a lot of things are being advanced to a degree that we're trying to eliminate the need for hospital stays and eliminate pain for a lot of patients. The other thing we can do is combine gastroenterology and colorectal surgery to excise a polyp that otherwise couldn't be excised in another manner. And this is something that, again, tries to eliminate the need for formal surgical resection. There's different platforms. There's a traditional incision, which is in the middle of the belly, or there's minimally invasive, which is robotic or laparoscopic. We try to do everything in a minimally invasive approach here, meaning usually put a camera in and make these tiny little pinhole incisions. And what we found is that the time for patients to recover, not only in the hospital, but at home, is greatly reduced. There's less pain, therefore there's less length of stay. Patients don't need to take a lot of narcotics. Cosmetically, it's better. They return to their life, active work. They return to that much quicker. We're starting to do things robotically, even though I think the robot is used as a very big marketing point. But the truth is, it actually hasn't been shown to be better for patients when it comes to colorectal care. It is a little more time under anesthesia, and it have a little more of a cost associated with it. But with that being said, we are doing things robotically. I just would be cautious to the surgeon, who says, "Oh, I can take care of everything robotically. You'll have no pain. You'll be home the next day." And that's not always the case. And then rectal cancer, is something that, oh, my slides got a little off. I'm sorry. Rectal cancer has certainly been shown time and time again that should be done by trained surgeons who do these operations routinely and not just once in a while. In fact, a lot of people are having permanent colostomy bags where they don't actually need to, if only they had seen a surgeon who is trained in colorectal cancer. The mortality, meaning death, is much lower if the surgeon does these operations a lot, and the chance of a colostomy bag, or certainly a permanent colostomy bag, is also much lower in patients that are seen by a surgeon who has extra training in dealing with rectal cancer. my God, I'm sorry, these slides, those arrows are supposed to be next to it. There is better survival overall, which I think is the important thing when it comes to cancer. The emergent 5-year survival, emergency cases overall survival is higher. Elective cases also higher. 30-day mortality lower. 90-day mortality lower. I'm sorry, those arrows for some reason shifted over. But the point is the arrows that are going up in a good direction, and the arrows that are going down are also in the right direction. Those are showing that looking at 13,500 people, the people who had an operation done by a colorectal surgeon did a lot better. And that's it. We touched upon hemorrhoids, fissures, diverticulitis, colon cancer, and inflammatory bowel disease.
Thank you so much, Dr. Schwartzberg, for your awesome presentation. Unfortunately, we don't have a lot of time for questions. We can definitely try and take one or two, so enter in any questions you may have. If we do not get to your question, please email it to us at matherhospital@northwell.edu. Again, that's matherhospital@northwell.edu. So that way we can have either Dr. Rajapaksa or Dr. Schwartzberg answer that for you. These slides actually are this entire presentation is going to be on our website. You could go to matherhospital.org/HealthyU. Again, that's matherhospital.org/HealthyU. And all of our pre-recorded content is also up there. Once you guys exit the webinar, there's going to be a link that pops up to complete a survey. It's extremely short, and your feedback is very important to us. And thank you, Dr. Schwartzberg. Everybody have a great rest of your day.